Dear students, I welcome all of you to this discussion of images in dermatology. I'm Dr. Malcolm, your faculty of dermatology at Marrow. In this particular session, how I'm going to approach this topic is in the form of clinical vignettes. We look at the clinical vignette, we make a diagnosis, we look at the image, we look at the morphology, configuration, and distribution, and thus we come to the right diagnosis. So I'm going to take it in the form of chapter-wise discussion. Let us start with the first chapter on basics in dermatology. So here we have a 7-year-old boy who presents to the dermatology clinic with 3-month history of persistent non-responsive seborrheic dermatitis, and electron microscopy reveals this finding. So what do we see here is we see these tennis racket shaped granules. And what is this appearance referring to? They are talking about the Burbeck granules. And which cell am I talking about here? Burbeck granules on electron microscopy is suggestive of a Langerhans cell. Next, we look at this non-invasive diagnostic tool in dermatology, wherein the skin is being examined under ultraviolet light. Yes, I'm talking about the Woods lamp examination here. And in a condition called as erythrasma, we can see the characteristic color which we need to remember for the exam. This is referred to as coral red fluorescence. So coral red fluorescence is seen in a corynebacterial infection called as erythrasma. A dermatologist is using a glass slide to perform the following test. So what is the dermatologist doing? He's taking a glass slide and pressing the lesions in dermatology. The name of this test is called diascopy. And in diascopy, what happens? We want to distinguish between erythema and purpura. Now, erythema is a condition characterized by vasodilatation. So what happens is when you take the glass slide and press, the blood from the vessels is pushed out, due to which the redness disappears temporarily, and this is called as blanching response. Whereas in a condition called as purpura, what happens here is there is extravasation of RBCs. So there's extravasation of RBCs, due to which, in spite of taking the glass slide and pressing the lesion, the red spots still persist here. They do not disappear, and this is called as non-blanching response. The next question is about a patient of psoriasis who is asked to enter a cabinet with multiple lamps for therapy. So what do we see here? We see multiple lamps here, which are ultraviolet lamps. It is going to give ultraviolet radiation to the patient, and this is called as a phototherapy unit. Phototherapy is used for 3 important purposes in dermatology. Number 1, for psoriasis. Number 2, vitiligo. And number 3, atopic dermatitis. Next, we move on to the chapter on appendages and disorders. So let us talk about the disorders of the hair, and let's start with non-scarring alopecia. So here we have a child presenting with patchy hair loss and nail changes. So when we look at this well circumscribed, smooth surfaced, circular patch of hair with complete hair loss, then we examine the nail, we see multiple punctate depressions in the form of this geometric pitting. Which disorder am I talking about? Yes, I'm talking about alopecia areata. What is alopecia areata? It is an autoimmune disease. What does it target? It targets the anagen hair bulb. It targets the anagen hair bulb. Let's look at the next scenario. A girl presents with bizarre patches of hair loss with broken hair of varying length. So this case scenario is talking about a condition called as trichotillomania, where tricho means hair, tillo means to pull, and mania is the obsessive compulsive nature of this disorder, wherein the patient is going to pull her hair out in a non-uniform pattern with inconsistent pressure, due to which you get broken hairs of varying length. Next is a child who presents with itchy areas of the scalp with patchy hair loss. When we examine the scalp, what do we find? We find that there are multiple black dots which are seen. So what do these black dots represent? So if this is the hair, the fungus goes into the hair and the hair breaks. Where is the hair breaking? Hair is breaking at the level of the scalp surface. This is referred to as Tinea capitis black dot type, and the type of invasion here is called as endothrix. Endothrix means the fungal spores have invaded into the hair shaft. Taking the next case scenario, there's a child presenting with itchy grey scaly lesions with patchy hair loss. Now on examination, you can find this greyish scaly area of the scalp with patchy hair loss. This is talking about Tinea capitis grey patch type. And if this is the hair, now we can see that the fungus is covering the hair. So the arthroconidia or the fungal spores are around the hair. That's why the hair is now looking greyish in color. And this is an example for ectothrix. The next scenario talks about a girl who presents with diffuse hair loss with history of dengue 3 months ago. So dengue is an example for severe systemic stress. It's an example for severe systemic stress. And following the systemic stress, what is going to happen? The hair from the anagen phase is going to prematurely move into the telogen phase. It remains there for 3 to 4 months and then diffuse hair loss is noted. This condition is referred to as telogen effluvium. Here we have a case of a male who presents with gradual hair loss, which is in a patterned way. So look at this pattern. This is frontotemporal recession. There is also family history of similar hair loss in a gradual pattern. So this condition is called as androgenetic alopecia, wherein there are androgens as well as genetic factors responsible for hair loss. Next, we move on to scarring alopecia. This is the example of a child who presents with a boggy scalp swelling. Easily pluckable hair, regional lymph nodes will be enlarged. Many a times in exam, they may give us also history of exposure to pet animal. So as soon as pet animal is given, that means this is definitely going to be a zoophilic fungus. This is going to be a zoophilic fungus. And in this background of tinea capitis, we are talking about chirion. Chirion is an example for inflammatory tinea capitis, which is happening because of a response, an inflammatory response to the zoophilic fungus. Here we are talking about a 58-year-old postmenopausal woman who notices a band-like area of hair loss over the frontal area of her scalp, rather frontotemporal area of the scalp, and there is also associated madarosis. So scarring alopecia involving the frontotemporal area, involving the eyebrows as well. This condition is called as frontal fibrosing alopecia. What is this condition, students? This is an example of, or rather variant of, lichen planopilaris. It's a variant of lichen planopilaris, and because the word fibrosing is there, we can assume that it must be scarring alopecia. Let us now move on to some disorders of the gland. So here we have a 30-year-old male who presents with itchy skin lesions over the axilla. On examination, we can see there are multiple pruritic skin-colored lesions, which are very, very itchy, predominantly distributed over the axilla. Can all of you make a diagnosis what it could be? Yes, this condition is called as Fox-Fordyce disease. Fox-Fordyce disease is also called as apocrine miliaria. It's also called as apocrine miliaria. That means there is blockage of the apocrine sweat duct. This is a case of an 18-year-old female who presents with asymptomatic skin lesions over the face. So what do we see here? We see a lot of open comedones, which are black in color. And we also see a lot of closed comedones, which are white in color. So comedones are special lesions of which condition? Yes, this condition is called as comedonal acne or acne vulgaris grade 1. And always remember, the best drug for grade 1 acne vulgaris is topical retinoids. The drug of choice for this condition is topical retinoids. Here we have a 26-year-old male who presents with painful skin lesions over the face of 6 months duration. So when we examine this patient, we can see there are multiple red, tender nodules and cystic lesions here. So this is talking about the most severe form of acne, which is called as nodulocystic acne. Here, this is also referred to as grade 4 acne. The drug of choice for grade 4 acne is isotretinoin. Isotretinoin. A 35-year-old female presents with history of flushing and photosensitivity with these lesions. So what do we see in the picture? We can see the presence of centrofacial erythema. So we are seeing this centrofacial erythema, and many times consultants often confuse this for acne as well. Always remember, students, that in this condition comedones are absent. With flushing, photosensitivity, telangiectasia, the correct answer here is rosacea, wherein rosacea is a disorder where the face is involved with chronic inflammation. A 45-year-old male presents with these asymptomatic skin lesions as shown in the image. So here we can see that there is thickening of the skin over the nose. There is bulbous enlargement and there are prominent pores. So thickening of the skin, bulbous enlargement, prominent pores. This is one of the representation of long-standing rosacea. This condition is called as rhinophyma. Rhinophyma is also known as potato nose. And very, very important to remember here is there is hypertrophy and fibrosis of the sebaceous gland. So sebaceous gland shows hypertrophy plus fibrosis in rhinophyma. Let us now move on to the chapter on papulosquamous disorders. Four important disorder, students, please keep it in mind. A 40-year-old male presents with reddish scaly lesions over the elbows and the knees of 2 years duration. So when we examine this patient, what do we see? We see multiple erythematous scaly papules and plaques. So we know in dermatology, if the solid raised lesion is less than 1 centimeter, we call it as a papule. If there's more than 1 centimeter, we call it as a plaque. So these are papules and plaques. Then we look at the scales of this patient. These are referred to as silvery white scales. These are referred to as silvery white scales. Then we take the glass slide, we perform something known as the Grattage test. And when we're performing this test, at the end, when we get pinpoint bleeding spots, we call it as Auspitz sign. And on examination of the nail, the most common nail change here is the presence of multiple irregular, coarse, deep pits. This condition we're talking about is called chronic plaque psoriasis, also known as psoriasis vulgaris. Next, we have a 40-year-old male who presents with itchy skin lesions. But here, please remember, the distribution is predominantly over the flexors. If you look at the previous picture, the distribution was predominantly over the extensor aspect of the body. Here, the distribution is predominantly over the flexors. And if you look at the color of the lesion, you can see these violaceous lesions over here. Violaceous color lesions. Another very important finding, you can see wherever there's trauma, there's appearance of new lesions. So we can see here, along the area or the line of trauma, appearance of new lesions. This is called as true Koebner's phenomena. And all of us should remember the three causes of true Koebner's. We have psoriasis, lichen planus, and vitiligo. So this is just a deviation. So we have a violaceous papules and plaques distributed over the flexors. True Koebner's is positive. Oral cavity examination, we can see this reticulate lacy white pattern. You're getting this lacy white pattern here. Now, when we examine the nail, what do we find? We find there is a wing-shaped extension here. We see the proximal attachment is to the proximal nail fold. The distal attachment is to the nail bed here. So this wing-shaped fold of projection is called as pterygium of the nail. This is called as pterygium of the nail. The diagnosis here is going to be lichen planus, which is yet another papulosquamous disorder. Now, a 40-year-old male presents with an initial large lesion over the chest. So when you see this initial large lesion of the chest, this lesion is known as Herald patch. When we zoom into this Herald patch, what do we see? We see a characteristic scale here. We can see that there is a fine peripheral scaling over here, and very important, it is within the edge of the lesion. So this is the edge of the lesion. So we see the scaling is within the edge of the lesion in the form of a collar. This is called as collarette of scales. And when we see the distribution, we see that the distribution is predominantly along the lines of Langer, the lines of skin tension. This is referred to as Christmas tree pattern. This is referred to as Christmas tree pattern. So Herald patch number 1, collarette of scales number 2, and Christmas tree distribution of lesions is number 3. The diagnosis is hinting towards pityriasis rosea, which is an acute self-limiting papulosquamous eruption. And the last condition from this chapter, a 45-year-old male presents with a 4-month history of generalized, progressively worsening red scaly patches. On examination, what do you see? You see multiple papules here, and these papules are around the hair follicle, so we call them as follicular papules. So this is point number 1. Point number 2, we see generalized erythema with or without scaling, distributed involving more than 90% of the body. If more than 90% of the body is red, in dermatology we call it as erythroderma. We call this as erythroderma. And in spite of more than 90% of the body getting involved, we can see this characteristic islands of sparing here. So the third point here is islands of sparing. So follicular papules is number 1, erythroderma is number 2, with islands of sparing is number 3. This is yet another papulosquamous disorder, which is referred to as pityriasis rubra pilaris. So please remember, students, pityriasis means scaling, rubra means red, pilaris means hair follicle. So just like in the previous condition where pityriasis means scaling, rosea means red color eruption or rose color eruption, here it's pityriasis rubra pilaris, yet another papulosquamous disorder. We now move on to the next very important topic on vesiculobullous disorders. Let us try to know the levels of fluid collection and their clinical correlation. For the exam, we have to remember three important levels. Number one, if the blister is below the stratum corneum, we call it as subcorneal. If the blister formation is above the stratum basal, we call it as suprabasal. If the blister formation is below the epidermis, we call it as subepidermal. So we have subcorneal, suprabasal, and subepidermal. Let us now look at the correlation of the various blisters. So a subcorneal blister is located just below the stratum corneum, due to which the type of blister we get is transient superficial very flaccid blisters are seen here. They are very flaccid because the roof is very thin here. These blisters will rupture very easily and they heal with normal skin. When you're talking about a suprabasal blister, the roof is thin now. When the roof is thin, the type of blister we get is flaccid blister. These flaccid blisters will rupture relatively easier. They leave behind erosions, and these erosions are going to heal with hyperpigmentation. And lastly, we have subepidermal blisters. When you're talking about a subepidermal blister, please remember, students, that the roof is going to be thick here. When the roof is thick, what happens? The type of blister we get is a tense bulla. So this tense bulla, what happens is the rupture is least readily. It generally does not rupture, and whenever it ruptures also, it leaves behind erosions which generally tend to heal with milia formation and scarring. So just by looking at very flaccid, and tense blister, we can guess in the exam, are we talking about subcorneal blisters, suprabasal blisters, or subepidermal blisters? Now let us see how to approach a bullous disorder via an MCQ. So if the bulla is given, try to identify whether it's a flaccid blister or a tense blister. If flaccid blister is mentioned, definitely the problem is in the epidermis. So it's an intraepidermal disorder. It's an intraepidermal blistering disorder. And this is going to be called as pemphigus group. This is the pemphigus group. Generally, pemphigus is a superficial condition, whereas if the tense bulla is given in the exam, that means the blister formation is subepidermal. The blister formation is subepidermal. We call it as the pemphigoid group. The pemphigoid group and dermatitis herpetiformis are going to have tense blisters. So this is how we distinguish based on flaccid or tense. And if the exam talks about flaccid blisters, look at the next clue given over there in relation to the mucosa. If the examiner says there's a flaccid blisters but mucosa is normal or there's no involvement of the mucosa, you have to mark your answer as pemphigus foliaceus. Pemphigus foliaceus, mucosal involvement is not there, whereas 90 to 95% of pemphigus vulgaris is going to have mucosal involvement. So based on the mucosa, we can distinguish between pemphigus foliaceus and pemphigus vulgaris. Let us now look at pemphigus foliaceus. Now this is an autoimmune blistering disorder where what is the target? It targets desmoglein number 1. It targets desmoglein number 1, which is there in the desmosomes. And these desmoglein number 1 is mainly expressed in the upper epidermis just below the stratum corneum. So I told you, whenever the split is at subcorneal level, what is going to happen? You're going to have a very transient blister, and this blister ruptures immediately, resulting in scales and crusts. So you're getting a scales and crusts, and the distribution is predominantly over seborrheic areas. So seborrheic areas means you're going to have involvement of the scalp, chest, and the back. And I've already mentioned to you that mucosa involvement is not there in pemphigus foliaceus. Very, very important. Mucosa is normal. That is because desmoglein number 1 is expressed in low concentration within the oral cavity. So because there is less expression of desmoglein number 1 in the oral cavity is spared in pemphigus foliaceus. And when we do a histopathology, identify the layers. This is stratum corneum. The split is just below the stratum corneum. So this is the subcorneal split. This is the last layer, which is stratum basal. So always when pictures are shown, identify the stratum corneum, identify the stratum basal, and look for the split. We now move on to the next topic of pemphigus vulgaris. Students, can you tell me what is the meaning of the word vulgaris? The vulgaris means most common. Vulgaris means most common. I already mentioned to you that pemphigus foliaceus targets desmoglein number 1, and pemphigus vulgaris is going to target desmoglein number 3 followed by 1. So 3 is more important in pemphigus vulgaris. How is the patient going to present? So please remember, this is called as a flaccid blister. Now how do we identify a flaccid blister? We can see the presence of this wrinkling on the surface. That means the tension must be low. It's a flaccid blister. These flaccid blisters will rupture to form erosions. And how do we identify these erosions in the exam? If the question tells us erosions tend to extend, no healing. This happens because of the acantholytic process over here. That means this is a pemphigus vulgaris question. And here, this is a characteristic sign where tangential finger pressure is applied over the skin. So when you apply tangential finger pressure over the skin, what is happening here? Here, the examiner is putting the pressure. You can see the upper layers of the skin separate from the lower layers. This is called as Nikolsky sign. So Nikolsky sign is positive both in pemphigus foliaceus as well as pemphigus vulgaris. So if Nikolsky sign is positive, what does it mean? It means the split is at the level of the epidermis. So it's the intraepidermal defect. So Nikolsky sign is positive in the exam. It means intraepidermal problem. When we look at the oral cavity, we can see the presence of these multiple erosions over here. So pemphigus vulgaris, 90 to 95% of the patients will have mucosal involvement. In pemphigus foliaceus, it is absent. Now we perform something known as Zank smear. Zank smear is what we do is we de-roof the bulla. We take the material from the base of the blister and we stain it with Giemsa. We're looking for the presence of this characteristic cell known as acantholytic cell. So this is how an acantholytic cell looks. It is a circular cell. It has a prominent nucleus and a perinuclear halo. So this is a acantholytic cell which is seen in the pemphigus group of disorders. This is also referred to as Zank cells. Let us now look at the histopathology of pemphigus vulgaris. So this is the stratum corneum and this is the stratum basale. So I told you the first step is always identify the layers. Now we can see the split is just above the stratum basale. So we call it as suprabasal split. So point number 1 is suprabasal split. Point number 2, we can see these circular keratinocytes here. These circular keratinocytes are referred to as acantholytic cells. They are referred to as acantholytic cells. And we can see that the basal keratinocytes are separate from each other, but they are vertically attached to the basement membrane zone. So this is referred to as row of tombstone appearance. This is referred to as row of tombstone appearance. So once again, to revise quickly, 3 important points in pemphigus vulgaris. Number 1, suprabasal split. Number 2, acantholytic cells. And number 3, you're going to have the attachment of the basal cells to the basement membrane zone. This is compared to row of tombstone appearance. Next, we move on to direct immunofluorescence, which is the investigation of choice here. So here what we do is we detect the immunoreactants which are depositing by fluorescein tagged antibodies. This is the investigation of choice. What do we get in pemphigus vulgaris? We get IgG3, intraepidermal, intercellular deposition, and this pattern is referred to as fishnet pattern. So this is the fishnet pattern that we see here. IgG3, intraepidermal, intercellular. Why is it intercellular? Because desmosomes are between the cells, and this pattern is referred to as fishnet pattern. Next, we look at the approach to tense bullae, which are autoimmune in nature. So whenever there's an autoimmune disorder, your direct immunofluorescence is going to be positive. There are 3 important subepidermal blistering disorders that we need to remember for the exam. So let us look at the clues here. If the question tells us it's an elderly patient, more than 60 years old, there are itchy bullae which are seen over red base. Generally, pemphigus vulgaris is seen on normal looking skin. Here, the bullae are seen on erythematous or urticarial base. Distribution is mainly over the trunk and the limbs, and it's IgG mediated. The correct answer for this question is bullous pemphigoid. So here, this is bullous pemphigoid. It is a disorder which targets the hemidesmosomes. It is a disorder which targets the hemidesmosomes. Next scenario is a patient with tense bullae with extremely pruritic condition. So intensely pruritic papulovesicles. Excoriation means scratch marks, and the distribution is predominantly over extensor aspect of the body. And very important clue here is one is it's IgA mediated and it's associated with gluten sensitive enteropathy. So gluten sensitive enteropathy or celiac sprue is the association of this condition. This condition is called as dermatitis herpetiformis. This condition is called as dermatitis herpetiformis. And lastly, we have yet another blistering disorder where the blisters are arranged in string of pearls appearance and it's IgA mediated. The correct answer for this question is CBDC, which is chronic bullous disease of childhood. Chronic bullous disease of childhood. Now let us look at the pictures. Now this is a bullous pemphigoid patient. You can see the stents, vesicles and bullae. You can see that on the surface there is no wrinkling, whereas in flaccid bullae generally the surface will show wrinkles. You can see the distribution, which is predominantly over the inner aspect of the thigh and the limbs. And see, this is the stratum corneum. This entire thing is the epidermis here, and you can see the bulla is just below the epidermis. So this is a subepidermal blister. You get a subepidermal split, and with this subepidermal split you can see some reddish cells here. These are going to be called as eosinophils. So very important cell which deposits in bullous pemphigoid is eosinophil. There is eosinophil recruitment in bullous pemphigoid. And now when we look at the direct immunofluorescence, we have to remember the three things: what is depositing, where is it depositing, how is it depositing. So here it's basically IgG-C3 which is depositing, and it is depositing along the basement membrane zone because the target here is hemidesmosomes and the pattern is linear. So we can see this linear deposition of IgG-C3 along the basement membrane zone. So this is the DIF finding of bullous pemphigoid. When we look at dermatitis herpetiformis, I already mentioned to you, get a lot of excoriated papulovesicles. That's why these tense blisters are very rarely seen, because it's a very, very itchy condition. You get these intensely pruritic papulovesicles, and the distribution, very important, they're distributed over the extensor aspect of the body. Then what we do is we do a biopsy. You can see this much is going to be the epidermis, and here you can see a subepidermal split. We notice that there is a subepidermal split, and you see a huge collections of neutrophil at the tip of the dermal papilla. This collection of neutrophils at the tip of the dermal papilla, this is referred to as papillary tip microabscess. Papillary tip microabscess. And lastly, now we go on to the DIF finding. What, where and how is depositing here. So here you have the IgA deposition along the basement membrane zone plus dermal papilla. So you can see the deposition is not only along the BMZ, it is also seen over the dermal papilla. And if you remember, in bullous pemphigoid, I use the word linear pattern. Here you can see an interrupted kind of deposition pattern. This is referred to as granular pattern. This is referred to as granular pattern. Next, now we look at the clinical presentation of CBDC. So you can see multiple tense vesicles which are arranged in an annular pattern. You can see this annular means ring-like configuration. So this ring-like distribution of vesicles and bullae, this is referred to as cluster of jewel, also known as string of pearl appearance. We move on to the next chapter on cutaneous drug reactions. Let us look at question number 1. A 32-year-old male is presenting with a well-demarcated round dusky red patch. So we can see this dusky red patch on the lip. He gives history of similar complaint 1 year ago following the intake of a NSAID. So the case scenario here is patient takes a drug, he gets a reaction at a particular site, and on re-intaking the drug, he gets it again at the same site. We are talking about fixed drug eruption. Now, why this condition is called fixed drug eruption? That is because the location of this drug reaction is fixed. And always remember, students, as we can see in the image here, it always heals with hyperpigmentation. It is always going to heal with hyperpigmentation. We move on to the next case scenario, wherein a 23-year-old male is presenting with a 3-day history of a rash which begins on the hand with minimal itching, history of cold sore on his lip 1 week ago. So what is cold sore? Cold sore is also known as herpes labialis. So though this case is in this chapter, it can also be induced by viral infections like herpes labialis. We look at the rash here, we can see the distal extremities getting involved. So number 1, you have distal extremities, and number 2, if you look at the nature, you have 1, 2 and 3. 1, 2 and 3. You can see 3 zones in this lesion. So these are referred to as target lesions. And please remember, students, target lesions are characteristic findings of erythema multiforme. What is erythema multiforme? It is a cytotoxic dermatitis. It's an example for a cytotoxic dermatitis. The most common virus which can trigger it is HSV1. Drugs also can be an implicated factor. Next, we move on to a 35-year-old male who presents with a 3-day history of a painful, rapidly spreading skin rash, fever, and malaise. Reports of starting a course of allopurinol for gout. So there is a drug here. There is a rapidly spreading skin rash here. If you look at the rash, what is this called? This is called as sheet-like epidermal peeling. So you can see the epidermis is peeling here, the sheet-like epidermal peeling. And if you look at the mucosal involvement, what is the name of this crust? This crust is known as hemorrhagic crust. These are called as hemorrhagic crust. There is very prominent mucosal involvement. There is skin involvement to the course of more than 30% body surface area. We're talking about toxic epidermal necrolysis. The word toxic means the patient usually has fever, there are systemic symptoms. Epidermal necrolysis, that is because here the keratinocytes are undergoing necrosis followed by lysis. Lysis means separation of the skin. That's why you get sheet-like epidermal peeling here. Next, we move on to case scenarios in infectious diseases. So this is going to be very important with the overlap between dermatology and microbiology. Case 1 is a child who presents with this. Look at this crust, everybody. What is the name of this crust here? We can call it as golden brown honey color crust. So we have a golden brown honey color crust which is distributed predominantly over the face, perinasal, perioral area. What are we talking about? Yes, this is non-bullous impetigo, also known as impetigo contagiosa. Second case is a child with fever presenting with this picture. So when you see this picture again, just like the previous case scenario, what do we see? We see sheet-like epidermal peeling. The sheet-like epidermal peeling here, and very important in comparison with toxic epidermal necrolysis where mucosa was involved. In this condition, mucosa is normal. That's because desmoglin 1 is getting targeted here, which is expressed in low concentration in the oral cavity. The correct answer here is staphylococcal scalded skin syndrome. The next case is a patient who presents with a nail fold swelling. It is filled with pus, there's erythema, and there's tenderness. This condition is called as acute paronychia. Paronychia is nail fold infection. The causative organism here is Staphylococcus aureus. So this condition would need drainage and would need antibiotics. Next, we have a case of an adult male who is diabetic, usually uncontrolled diabetes. So we can see the presence of this red tender nodule here, usually on the nape of the neck. There are multiple pustules and there's uncontrolled diabetes. This is talking about a carbuncle. Carbuncle is a condition, a bacterial infection of the skin where there's multiple hair follicles getting involved with contiguous area. So this condition usually goes to the surgery department. An uncontrolled diabetic patient with a red tender nodule with multiple pustules on the surface is going to be our carbuncle. Next, we have an adult male who presents with this asymptomatic reddish brown hyperpigmentation. So we have this reddish brown hyperpigmentation, and we see the distribution over here is predominantly going to be over the axilla. So this condition is called as erythrasma. Eryth means red. That's why you get this reddish brown hyperpigmentation over here. Erythrasma is produced by which organism? It is Corynebacterium minutissimum. It's produced by Corynebacterium minutissimum. Next, we have an adult male who presents with yellowish discoloration of the axillary hair. This condition is called as trichomycosis axillaris, produced by, from the letter T we can remember, Corynebacterium tenuis. And though the word mycosis is there, it is not a fungal infection, it is a bacterial infection. You can see the yellow colored axillary hair here. Next case is about an adult male who presents with these asymptomatic slow growing lesions. So what do we see in the picture? You can see a plaque, and you can see it's an infiltrated plaque. You can see this a gradually enlarging plaque, point number 1. Point number 2, you can see the central atrophy plus scarring. You can see there's a lot of scarring. So this condition will destroy and move ahead just like a wolf. That's why this condition is called as lupus vulgaris. It is a form of cutaneous tuberculosis. For that matter, the most important cutaneous tuberculosis which is seen in adults. So identifying points are an annular infiltrated plaque with central atrophy and scarring, usually seen on the face, buttocks, and the extremities. Next is a case of a child who presented with history of painless nodules. These nodules ruptured to form sinuses, and you can see some sinuses and skin lesions over here. There are a few fibrotic scars as well. If they show you a picture of the neck, they're probably talking about cervical lymph nodes being the focus of infection in this condition. This condition is known as crofilloderma. This is the most common cutaneous tuberculosis in a child. So the identifying points would be there are painless nodules, they rupture into the skin resulting in sinuses, fibrotic scars. Usually the ulcers here are going to have an undermined edge. So this is called as scrophaloderma. The next case is a 32-year-old male who presents with history of fever, this headache and generalized body ache, and this skin lesion. So what do we see here? We see a black scab surrounded by erythema. So if there's black scab surrounded by erythema, this is called as an eschar. And in this case scenario, the correct answer is going to be scrub typhus, which is a rickettsial disease which is transmitted by trombiculid mite. The next case is of a child with fever, headache and neck rigidity. So when we have fever, headache and neck rigidity, the examiner is telling you there is meningitis. There's meningitis, and with this meningitis you can see a rash. What is the name of this rash? This is going to be a petechial rash. You remember I discussed in the earlier part of the chapter that petechiae or purpura are non-blanchable on endoscopy. So child with features of meningitis and petechiae, we're talking about meningococcal meningitis. The next case is of a 30-year-old male who presents with asymptomatic skin lesions. So we can see there are multiple hypopigmented, minimally scaly lesions over the back. This condition is called as pityriasis versicolor. Pityriasis means scales. The type of scales you get is fine, brany, perforaceous scales. Versicolor means it can come as both hypo as well as hyperpigmented. Hypopigmented is the most common presentation. The next case is of a 26-year-old male who presents with a solitary itchy skin lesion on the chest. So we see there is an annular plaque, we see the central clearing. With this background, the correct answer has to be tinea corporis. So tinea corporis, when I say tinea, I'm talking about dermatophyte infection. It's a dermatophytic infection. So you have annular plaque, central clearing, peripheral raised scaly margin, and it is associated with itch as a clinical feature. Next is a case of an HIV infected patient who presents with his white lesions. And very important clue here, students, is white lesions which can be rubbed off. So kindly focus on this can be rubbed off. So it can be rubbed off because it's a pseudomembrane, white pseudomembranous plaques. We're talking about oral candidiasis. Oral candidiasis is also known as oral thrush. It's also known as oral thrush. Next is a case of a gardener who gives history of thorn prick. So after thorn prick, what is happening? You can see this lesion. There's a gardener with history of thorn prick. You have nodulo-ulcerative lesions. They show proximal extension and linear pattern of lesions. Why is it linear pattern? Because of involvement of the lymphatics of the extremity. So if this case scenario is given where you have a gardener with history of thorn prick, nodulo-ulcerative lesion, proximal extension, linear pattern along the lymphatics of the extremity, we're talking about sporotrichosis. Sporotrichosis is also known as Rose Gardner's disease. Also known as Rose Gardner's disease. So next is a case of a farmer who presents with history of vegetative trauma. So after there is vegetative trauma, you're getting nodular lesions. You can see everybody, the nodular cauliflower-like lesions which are seen on the foot. So as soon as a foot picture is shown, many students make a mistake and mark it as mycetoma. Please students look at the case scenario. If the farmer with history of vegetative trauma, but the lesions are nodular, cauliflower-like or verrucous lesions. Verrucous means anything which is rough in dermatology. You mark your answer as chromoblastomycosis, which is a type of subcutaneous mycosis. Why this condition is called as chromo? Because it is produced by pigmented fungi. And when you do a potassium hydroxide mount, what do you see? You see this brown, round, thick-walled bodies. Brown, round, and thick-walled bodies. What are the names of these bodies? These bodies are also referred to as copper penny bodies, sclerotic bodies, and medlar bodies. Next is a case of a farmer with history of trauma. And when this trauma, after that, what do we see? We see there is swelling, which is known as tumefaction. There are multiple sinuses which are formed, and then you get discharging granules. This triad of tumefaction, sinus formation, and granules is in favor of mycetoma. Please remember, students, mycetoma can be both. If it is fungal, we call it as eumycetoma. If it is because of fungus, if it is bacterial, we call it as actinomycetoma, which is produced by aerobic filamentous bacteria. Next is a case of an 8-year-old boy who presents with nocturnal pruritus, family history of the same, and this itchy lesion. So what do we see? We see multiple excoriated papules. Where are they distributed, students? They're distributed over the web spaces of the fingers. This history of similar complaints among family members as well. We're talking about scabies, which is produced by the itch mite. Next, we have a child from Jaipur who presents with a skin lesion on the cheek. Look at this lesion, everybody. You can see that there is a annular plaque. You can see in the center, what is very, very characteristic is central crust. So this central crusting, and generally when you remove the crust, you will get an ulcer over here. So a child from Jaipur presenting with a nodulo-ulcerative lesion with central crusting is talking about cutaneous leishmaniasis. So this is how you diagnose cutaneous leishmaniasis. And yet another case scenario with the same context is a 25-year-old male from Bihar who presents with skin lesions on the face and the back. There is no scaling. Very, very important is no scaling, because when you generally look at this image, you tend to mark it as pityriasis versicolor. But please remember, pityriasis versicolor is a scaly condition. This history of prolonged fever in the past, what is the examiner trying to tell you? It's trying to tell you that it could be visceral leishmaniasis in the past. Visceral leishmaniasis was there in the past. Why the examiner is telling us peripheral nerves are normal? To rule out lepromatous leprosy. That means it is not lepromatous leprosy. So we rule out lepromatous leprosy because there are peripheral nerves are normal. There's no scaling, so pityriasis versicolor is normal. A patient with Kala Azar later on in life developing these multiple hypopigmented macules on the trunk, the diagnosis is going to be post Kala Azar dermal leishmaniasis. Next, we have a 26-year-old girl who presents with these migratory itchy lesions on the foot of 3 days duration. She gives history of walking barefoot on the beach. So when you're walking barefoot on the beach, you might have come in contact with animal hookworm larva. So please remember, students, it is not human hookworm larva, it is animal hookworm larva, especially Ankylostoma brasiliensis, Ankylostoma caninum. So Ankylostoma brasiliensis and Ankylostoma caninum. The correct answer for this question is cutaneous larva migrans, which generally moves at a speed of 1 to 2 centimeter per day. Next, we have a case of a 35-year-old lady who presents with this asymptomatic skin lesion. So look at the skin lesions. What do you see? The surface is slightly rough. So in dermatology, if there is anything which is rough, uneven, or has a warty surface, we call it as verrucous. So that means these papules are verrucous papules. The correct answer for this question is verruca vulgaris. Please remember, students, the HPVs which producing this are not 6, 11, 16, 18. Here it is going to be 2, 4 and 27. The next case is a child who presents with asymptomatic whitish lesions. So we can see these asymptomatic pearly white dome-shaped lesions, which occasionally can have central umbilication as well. So this condition is molluscum contagiosum. And when we take a biopsy of molluscum contagiosum, what do we see? We see a cup-shaped invagination of the epidermis into the dermis. And we see this multiple eosinophilic intracytoplasmic bodies. These bodies are called as Henderson-Patterson bodies. So these are the Henderson-Patterson bodies. Next is a case of a patient with recurrent skin lesions on the lip. So when we look at the lesion here, we see 3 points. Point number 1, the lesion is vesicles. Point number 2, it is arranged in a group pattern. Point number 3, it is along the lip margin. So vesicles, grouping and lip margin, our diagnosis is going to be herpes labialis, also known as cold sore or fever blister. Next is a case of an adult male who presents with 3-day history of excruciating pain followed by the skin lesions. So when we look at the skin lesions, we see 3 things. Point number 1, the lesions are unilateral. Point number 2, the lesions are dermatomal. Point number 3, painful grouped vesicles on red base. So if we have these 3 points, point number 1, it's unilateral. Point number 2, it's dermatomal. Point number 3, painful grouped vesicles on red base. The correct answer for this question is going to be herpes zoster. So herpes zoster is also known as shingles. And it is produced by which virus, everybody? It is going to be produced by varicella zoster virus. So next is a case of an HIV infected patient who presents with a white plaque. You look at this white plaque, it has got some corrugations. Corrugation means thrown into folds. So HIV infected patient presents with a white corrugated plaque, lateral border of the tongue, very, very important, cannot be rubbed off. If you remember, students, I told you HIV patient white plaque can be rubbed off. Think of oral candidiasis. HIV patient white plaque which cannot be rubbed off. Think of oral hairy leukoplakia, which is produced by Epstein-Barr virus. Next is the case of a child who presents with fever with skin lesions of the palm, soles, buttocks and oral cavity. So you can see this oval elliptical vesicles with an erythematous halo around it. So when you have these oval vesicles distributed predominantly over the palm, soles, buttocks and oral cavity, the correct answer is going to be hand, foot, mouth disease, which is produced by Coxsackie A16 and enterovirus number 71. Let us now take up case scenarios from sexually transmitted diseases. Starting with number 1, an adult male with history of high-risk sexual exposure presents with his asymptomatic lesions on the genitals. On examination, we see asymptomatic, fleshy, pink papules and plaques. So when you have these asymptomatic, pink, fleshy, pointed papules and plaques, the name in dermatology for pointed is acuminata. So acuminata means pointed. So these pointed lesions over the genitals are talking about anogenital warts, also referred to as condyloma acuminata. Next, we have an adult male with history of high-risk sexual exposure. Again, asymptomatic lesions, but look at the morphology, everybody. Here you see these asymptomatic lesions which are flat-topped and moist. Very important. Flat-topped, they are moist lesions. Just like acuminata means pointed, lata means flat. So this is condyloma lata, which is talking about the flat top lesions, moist lesions, which are seen in secondary syphilis. This can also be associated with moth-eaten alopecia over the scalp. Next, we have an adult male with history of high-risk sexual exposure, and 2 days later, the urethral discharge we can see is profuse and purulent. So, what is the meaning of the word gono? Gono means seed. Rhea means flow. This condition was called gonorrhea because of the profuse purulent urethral discharge which comes from the meatus. That's why this condition is called as gonococcal urethritis. It has a short incubation period of generally 1 to 2 days. In vaginal discharge disease, 3 conditions to note. If a patient presents with curdy white vaginal discharge, we will mark it as candidiasis. If there is greenish yellow frothy discharge with multiple punctate hemorrhages over the cervix, so greenish yellow frothy discharge with strawberry cervix, it's going to be trichomoniasis. And a patient presenting with homogeneous white adherent discharge stuck onto the vaginal walls, think about bacterial vaginosis. Now let us take up a very important topic of genital ulcer disease. So in this context, what we do, we examine the genital ulcer, then we examine the inguinal lymph nodes. So ulcer examination, lymph node examination. Let us look at the genital ulcer disease. We classify the genital ulcers into 2 categories, single and non-tender, multiple and tender. Under single and non-tender category, we have 3 important diseases. Number 1, we look at this genital ulcer disease where you get beefy red granulation tissue which bleeds on touch. So if you have beefy red granulation tissue of the ulcer, the answer is going to be donovanosis. If a patient presents with a hard chancre, so this is a hard chancre which is generally single, clean based, indurated, non-tender, does not bleed on touch. Think of primary syphilis. And here we can see our ulcer, but very important here is a transient genital ulcer. This ulcer will be there for some time, then it disappears, then our diagnosis becomes lymphogranuloma venereum. So these are the 3 causes of single non-tender genital ulcers, and to distinguish between them, you examine the inguinal lymph nodes. In context of donovanosis, please remember students that inguinal lymph nodes are normal in this condition. So inguinal lymph nodes are normal in this condition. In syphilis, what happens is you get bilateral, non-tender, enlarged, rubbery lymph nodes. So the consistency of the lymph nodes here is going to be called rubbery. Whereas in LGV, what we're going to get is you're going to get a bubo. What is a bubo? Bubo is an enlarged lymph node which is tender, which is filled with pus, suppurative inguinal lymphadenopathy. So in LGV, what happens is when the bubo is present, at the same time when you examine the ulcer will be absent over the genitalia. This is called as concomitant genital ulcer absent, which is very, very important in the context of LGV. Then when we examine a patient with multiple tender genital ulcer, there are 2 important differential diagnoses. If a patient has vesicles, so you can see these grouped vesicles, then we talk about genital herpes. And if a patient has multiple tender ulcers, which is also referred to as soft chancre, then the differential becomes chancroid. Now, how to distinguish between these 2 conditions is again based on the inguinal lymph nodes. What is going to happen is in genital herpes, you get bilateral, enlarged, tender inguinal lymph nodes. We remember in primary syphilis, I told you they are non-tender and rubbery. Here it is tender. Whereas again in chancroid, we're going to get a bubo over here. And if you look at the bubo here in chancroid, when the bubo is present, at the same time when you examine the genitalia, ulcer is present. So you can see a genital ulcer over here, which was absent in lymphogranuloma venereum. That is how we distinguish between chancroid and LGV. Next, donovanosis, I already mentioned to you, inguinal lymph nodes are normal. However, in the inguinal region, you can see a subcutaneous nodule in the groin. This subcutaneous nodule in the groin is called pseudobubo because it is not a lymph node. It is basically a subcutaneous nodule in the groin. Next, we move on to the lab diagnosis. So, in the gram stain from a urethral discharge, if you're going to get gram negative intracellular diplococci, as you can see here, frequently intracellular, but you can get it extracellular as well. This is going to be gonococcal urethritis. And when you do a wet mount of a vaginal discharge, if you see this vaginal epithelial cell with a fuzzy border, that's because the surface is sort of covered with bacteria. These are going to be called as clue cells. Clue cells, if they are more than 20%, are suggestive of a diagnosis of bacterial vaginosis. Then when we look at the gram staining smear of a genital ulcer, if you get gram negative cocobacilli arranged in long parallel strands, then the diagnosis is going to be chancroid. And if you take a Zank smear from the genital ulcer, if you get multinucleated giant cells, then it is going to be called as genital herpes. So the name of the cell here is multinucleated giant cells. Why does it happen? It happens because this virus can produce cytopathic effect. So there is fusion of these cells as a part of cytopathic effect, which is demonstrated by herpes simplex virus. And lastly, when you have a beefy red genital ulcer, what you do is you take a crushed tissue smear. You take the tissue, you crush it between two slides and you examine the slides. If you get this large monocyte, which is called as a Pund cell, and inside the Pund cell, you can see the organism which shows bipolar condensation of chromatin. We are talking about donovanosis, and this bipolar condensation of chromatin, this is called as closed safety pin appearance. This is closed safety pin appearance. Let us now look at case scenarios from Hansen's disease. A 6-year-old male child resident of Bihar presents with an ill-defined hypopigmented macula on the face, no scaling, no sensory loss. So, a resident of Bihar, a child, is basically talking about endemicity. So, endemic region for leprosy being Bihar, one of the states. Ill-defined hypopigmented macula on the face, no scaling, no sensory loss. This form of leprosy is an early form of leprosy. It's called indeterminate leprosy. Why is it called indeterminate leprosy? Because the CMI is not well established. So the CMI is not well established. It represents the initial encounter of the body to Mycobacterium leprae. That's why we get indeterminate leprosy. Now in the exam, what is the most important differential diagnosis for this condition? Yes, the differential diagnosis for this condition is pityriasis alba. As I mentioned to you students, please remember this point that leprosy is non-scaly, whereas the word pityriasis itself means scaling. So scales are present here. You get fine scales in pityriasis versicolor. Generally, there are multiple lesions. Usually in indeterminate leprosy, there's only single patch. Next, we go on to determinate leprosy. What do I mean by determinate leprosy? That means here the CMI is well established. That means you will definitely get a definitive form of leprosy here. This has been classified by Ridley and Jopling into 5 important types. TT leprosy, which is tuberculoid type. BT is borderline tuberculoid. BB is mid borderline. BL is borderline lepromatous, and LL is lepromatous leprosy. One thing we need to know in leprosy is as you move from TT to LL, what is going to happen? Your cell mediated immunity goes on decreasing, and your acid fast bacteria, Mycobacterium leprae, goes on increasing. Let us now try to understand what are the different changes happening when you move from TT to LL. So when you're moving from TT to LL, first let us look at the CMI. The CMI is strong in TT, whereas in LL it is poor. Because of the strong CMI, what happens? You get a very good, well-defined granuloma in TT, whereas in LL, because of the poor CMI, you're going to get only foamy macrophages. There are no well-formed granulomas, only foamy macrophages here. The lepromin test is directly proportional to our cell-mediated immunity. If the immunity is higher, the test will come positive. If the immunity is lower, the test will come negative. That's why in TT leprosy, lepromin test is positive, and in LL, it is going to be negative. The slit skin smear for M. leprae is going to be negative in TT because there are only few bacilli which cannot be picked up by the test, whereas in LL, there are numerous bacilli. That's why the test will come positive here. Let us now look at the clinical features in terms of the skin and the nerve involvement. In TT leprosy, what happens? The number of skin lesions are going to be 1 to 3. Whereas in LL, it is innumerable. You can't even count it. That many number of lesions are going to be there. Symmetry of the lesions. Since TT has got few lesions, generally it's going to be asymmetric. More the lesions, more the symmetry. That's why LL leprosy is characterized by symmetric involvement of the skin and nerves. Margin of the lesion. If the immunity is strong, good immunity, you get well-defined margin because the body wants to seal off the bacteria so that the bacteria doesn't go off. Whereas in LL leprosy, what happens is poor CMI, so you get diffuse margins, ill-defined margins because there is uncontrolled multiplication of the bacteria. In terms of sensation over the skin lesions, in TT leprosy, you get a very good granuloma which will compress on the nerves, resulting in anesthesia. So usually there is loss of sensation, whereas in LL leprosy, what happens? You get only foamy macrophages. So at least initially in the disease, what will happen? The sensation over the skin lesions are preserved because there's no compression by the granuloma. Initially, the sensation over the skin lesions are going to be preserved in lepromatous leprosy. In terms of nerve involvement, there are few nerves which are involved, generally asymmetric in TT, whereas in LL, you're going to have multiple symmetric thickening of the peripheral nerves. Let us now look at TT leprosy. Generally, there are going to be 1 to 3 skin lesions. You can see a very well-defined margin. You can see a well-defined margin over here. And due to this granuloma, what happens? It destroys all the nerves, resulting in anesthesia, all the hair, resulting in alopecia. All the sweat glands are destroyed, resulting in anhidrosis. So anesthesia, alopecia, anhidrosis is the feature of TT leprosy. In BT leprosy, the number of lesions goes on increasing. They are around 3 to 10 in number. You get well-defined, not so well-defined, well-defined, not so well-defined, and you get a characteristic lesion in the periphery. This is called as satellite lesions. You get satellite lesions. So you can see this. Adjacent to the main lesion, the bacteria now tries to move out of the boundary which was set in TT, and you get a small peripheral lesion called as satellite lesions. You go to BB leprosy, it's very, very unstable form. You get around 10 to 30 skin lesions. This is the most unstable form of leprosy. You can see the variety here. You can see few small lesions, intermediate lesions, large lesions, very large lesion. You get polymorphic skin lesions compared to the map of a country. That's why it's called geographic map-like appearance. And then this BB leprosy is right in the center. It has few properties of TT. It has few properties of LL. You have an inner border, which you can see is punched out. And you can see the outer border of the lesion is sloping. So inner border is punched out, outer border is sloping. The inner border which is punched out is compared to Swiss cheese appearance, which is seen because of the punched out inner border, which is well defined, represents TT, whereas if you see the outer margin which is sloping outwards, this is compared to the outer sloping margin of an inverted saucer. That's why this is referred to as inverted saucer appearance. But please remember for the exam, inverted saucer is not only seen in BB, can also be seen in BL leprosy. Next, we move on to BL leprosy. So in BL leprosy, what happens is we are going to have more than 30 skin lesions, and here they are going to be numerous in number. So this is going to be point number 1. Point number 2 is you see that there are multiple skin lesions which tend to symmetry. They are almost symmetrical or they are tending to symmetry. So both skin lesions as well as peripheral nerve involvement is tending to be symmetrical in BL leprosy. When we come to lepromatous leprosy, please remember students, it's a systemic disease. That means not only skin is involved, you also have nerve involvement and organ involvement. The number of lesions here are innumerable. That means we can't even count them. And here we always use the word symmetrical. So we have symmetrical thickening of the nerves and symmetrical distribution of macules, papules or nodules. And then later on in leprosy, what can happen is there is thickening of the skin over the face, multiple furrows, infiltration of the bacteria throughout the skin happens. This is referred to as leonine facies. Lion-like facies because of infiltration of the bacteria or the skin of the face. And then this was a recent exam question. A 50-year-old patient of Hansen's on treatment presents with the following skin lesion. What do we see is because of the peripheral neuropathy which is associated with Hansen's, what you can get is you get a characteristic ulcer. This ulcer is known as trophic ulcer. So trophic ulcer is basically an ulcer, a chronic ulcer of an anesthetic foot. Also referred to as neuropathic ulcer. When we look at the histopathology of lepromatous leprosy, we identify the epidermis over here and we see below the epidermis there is a subepidermal free zone. This zone is referred to as Grenz zone. It's a subepidermal free zone without any cellular infiltrate. And if you look at the cellular infiltrate which is below, you get diffuse sheets of foamy macrophages. These foamy macrophages have got acid-fast bacteria. These are referred to as virchow cells, also referred to as lepra cells. Virchow cells, also referred to as lepra cells. And moving on to the treatment, we need to remember the standardization of the treatment now. We have paucibacillary and multibacillary. In paucibacillary, please remember students, this is an update, no nerve involvement. So if there is zero nerve involvement, we give paucibacillary treatment. Multibacillary treatment, one nerve or more, is going to be multibacillary. So you have 1 to 5 skin lesions, 6 or more skin lesions, slit skin smear for AFB negative, slit skin smear for AFB positive. This is an update you need to remember. No nerve, paucibacillary. Even if there's one nerve, we have to give multibacillary treatment. The duration of treatment is going to be 6 months for paucibacillary. For multibacillary, it's going to be 12 months. And we are going to give all the 3 drugs in both paucibacillary as well as multibacillary treatment. An adult male with Hansen's is started on MBMDT and then he develops signs of inflammation. So multibacillary multidrug therapy is going on. When you develop signs of inflammation, we are thinking about lepra reaction, which is immunologically mediated episodes of acute inflammation, which happens during this chronic disease called as leprosy. We have type 1 lepra reaction and type 2 lepra reaction. So how do we distinguish between the two is, in type 1 lepra reaction, usually seen in the borderline spectrum. This is point number 1. Point number 2, it is an example for a type 4 hypersensitivity reaction. And here, the existing skin lesions, whatever patches were there over the patient's body, they suddenly become red, erythematous and tender, and you get very severe neuritis. So neuritis is the hallmark of this condition. When we're looking at type 2 lepra reaction, which is type 3 immune complex mediated disorder, it is seen in the lepromatous spectrum. It's usually seen in BL and LL, and here new skin lesions come up. Now we understand the difference, everybody, that in type 1 lepra reaction, existing patches become red. In type 2 lepra reaction, new red tender nodules come. That's why we call it as ENL. ENL stands for erythema nodosum leprosum, the red color nodules which are seen in leprosy. And here, very important, is nerves may be involved but may not be involved, but very severe constitutional symptoms in the form of fever is going to be present in type 2 lepra reaction. Looking at this image of a patient with lepra 1, so this was a patient who had a white patch on the face, and when it undergoes the reaction, the existing patch suddenly becomes red, edematous and tender, whereas in type 2 lepra reaction called as erythema nodosum leprosum, which is an example for a type 3 hypersensitivity reaction, you get red tender nodules which come and go. So evanescent red tender nodules, that's type 2 lepra reaction. Let us move on to this PSM based question, which is talking about the National Leprosy Eradication Program logo. So here we have the lotus, which represents beauty and purity. And here, this is representing the partially affected thumb, which is holding this lotus. So this is the partially affected thumb. What does it tell us is that leprosy can be cured and a leprosy patient can be a useful member of the society. And lastly, you have the rising sun. This rising sun represents hope and optimism in the entire program. In the session 2 of the exam, this mascot was shown for National Leprosy Eradication Program. The name of this mascot is Sapna. Now, Sapna is basically a girl who is going to propagate the message and awareness about leprosy in the community. So this mascot which is chosen is called as Sapna. We move on to the next section on urticaria and eczema. A 35-year-old female presents to the dermatologist with 6-month history of recurrent itchy skin lesions. These lesions appear suddenly, last for few hours, disappear and then reappear. That means this history is suggestive of the lesions being transient. That means they come and go. Central pallor peripheral erythema, we're talking about wheals here. And wheals are seen in a disease called as urticaria. And if urticaria happens without any exogenous trigger, we call it as chronic spontaneous urticaria. Next, we have a 4-year-old boy who presents with 6-month history of persistent brownish skin spots. So you can see these brownish skin spots over here. Whenever these lesions are rubbed or scratched, they become raised and itchy. What could be there inside the skin lesion? Probably there are mast cells in this lesion. So when you scratch them, what happens is histamine is released and it produces erythema with the urticarial halo. Clinically, we call this as Derrier sign. And this disease where mast cells are proliferating in the skin is referred to as cutaneous mastocytosis, also referred to as Urticaria pigmentosa. This condition, everybody, is also referred to as Urticaria pigmentosa. Next, we look at the morphologies of eczema. So we have two stages of eczema, acute and chronic. In acute eczema, we have all the signs of acute inflammation, erythema, edema, vesicles, oozing and crusting. That means an acute inflammation is going on. In chronic eczema, what happens is if you continuously rub or scratch one part of your body, what happens? Number one, your skin will become thicker. Number two, your skin becomes darker. And number three, there are exaggerated skin markings. So thickening of the skin, exaggerated skin markings, and hyperpigmentation together is referred to as lichenification. Together is referred to as lichenification. Next, we have a 35-year-old woman who's been having recurrent itchy red scaly lesions on the hands and face. In order to confirm the diagnosis and to identify allergens causing the reaction, a test is being performed. So we can see this test here where allergens are applied over the back. What is the name of this test? Yes, it's called as a patch test. It is an example for type 4 hypersensitivity reaction. And if they ask us in the exam, patch test is read at, the answer is going to be 2 days. If they ask us for the best reading, the answer is going to be 4 days. Next, we have a 52-year-old male farmer with 1-year history of persistent itchy rash on the face, neck and the hands, which is progressively worsened. And this farmer gives history of exposure to this particular plant. So what is the name of this plant? This plant is called Parthenium hysterophorus. And the name of the allergen is SQL, which is sesquiterpene lactone. Sesquiterpene lactone. What does Parthenium hysterophorus produce? It produces something known as airborne contact dermatitis. So airborne contact dermatitis happens because the allergens will settle in the air and the exposed parts of the body are going to get affected here. Next, we move on to atopic dermatitis, which is a chronic, relapsing, inflammatory skin disease. So every patient in dermatology, generally we ask history of atopy. So what do I mean by atopy? Atopy is localized type 1 hypersensitivity reaction. We ask for 3 important points: recurrent sneezing in the upper respiratory tract, so that's allergic rhinitis. In the lower respiratory tract, we ask history of bronchial asthma, and in skin, we ask history suggestive of atopic dermatitis. There are 3 important phases of atopic dermatitis: the infantile phase, childhood phase, and the adult phase. Infantile phase is up to 2 years of life, where you can see the face is involved, the scalp is involved, and the extensor aspect of the body gets involved, because when the baby crawls, these are the parts which are going to come in contact with the ground, and that's why they eczematize. However, in the childhood phase, which is seen usually between 2 years and puberty, the distribution is going to shift, and it involves the flexural aspect of the extremities. And in the adult phase, which continues beyond puberty, again you get a lot of lichenified papules and plaques with again flexural predominant distribution. And this is the lichenification I was talking about. You have thickening of the skin, hyperpigmentation, and exaggerated skin markings. So these were the 3 phases of atopic dermatitis. And one important feature we see usually when we examine an atopic child is you can see an infraorbital fold of skin. This crease of skin is referred to as Denny-Morgan's fold. Next, we move on to questions on pigmentary disorders. A 40-year-old woman presents with dark patches on her face that have progressively worsened over the past year. So here we can see the presence of symmetric hyperpigmented macules, which are distributed over the nose and the malar area. We're talking about a condition called as melasma, which is an acquired disorder. A 2-year-old child is brought in by her parents with large dark color patch on the face since birth. So when it says since birth, it has to be congenital. And we look at this lesion here. We look at this lesion, which is well demarcated, hyperpigmented. It's hypertrichotic as well. So you can see there are multiple hair strands on the surface of the lesion. This condition is called as congenital melanocytic nevus. This basically happens because of benign proliferation of the melanocytes, but this is happening since birth. This is the case of a 16-year-old male who presents with a large dark patch on the right chest. You can see this darkish lesion here. And when you examine, you can see again there are hair strands. This is hypertrichotic, but this is an acquired condition because it's there only since 3 years. The age of the patient is 16 years old. Now we are going to make a diagnosis of Becker's nevus. So please remember, students, congenital melanocytic nevus is congenital. Otherwise, it is similar. It's unilateral, hyperpigmented, hypertrichotic, whereas here it's an acquired condition. So this is going to be the key word in the differentiation of congenital melanocytic nevus and Becker's nevus. Here we have a 20-year-old female who presents with this bluish grey discoloration on the left side of the face since childhood. On examination, you can see it is unilateral. It is blue to grey in color. It is in the distribution of the first and the second division of the trigeminal nerve. The first division is ophthalmic, the second division is maxillary. This nevus is referred to as nevus of Ota. So this is an example for something known as dermal melanocytosis. So generally, when we're talking about the proliferation of the melanocytes in the dermis, the color is going to be blue to gray in color because of something in physics known as Tyndall effect. A 20-year-old female presents with asymptomatic whitish skin lesions on the left side of the abdomen since early childhood. Initially, it shows rapid progress and then stabilizes. This point is very, very important, has been tested twice in the exam. Rapid progression and then stabilization. This course is referring to segmental vitiligo. Vitiligo is a condition characterized by loss of melanocytes, and here we can see this unilateral distribution, segmental distribution, a course which has a rapid progress and then stabilizes. This vitiligo is called segmental vitiligo. A 40-year-old female presents with generalized asymptomatic white skin lesions. So we can see these bilaterally symmetrical depigmented lesions. So these are called depigmented lesions because melanocytes are absent. The most common type of vitiligo is vitiligo vulgaris. There's also history of thyroid dysfunction which is mentioned. This is again pointing out towards autoimmune etiology. A 40-year-old female presents with an asymptomatic white skin lesion on the forehead. You can see this whitish lesion over here. What is it corresponding to? It is corresponding to the placement of a bindi. The most important allergen in bindi is PTBP, para-tertiary butyl phenol, which is there in the adhesive which attaches the bindi to the forehead. This condition is called chemical leukoderma, where the chemical is destroying the melanocytes. Now we take some cases from skin and rheumat. A 7-year-old boy is presenting with rash, abdominal pain and joint swelling for the past 2 days. On examination, you can see a symmetric rash which is erythematous in nature. Generally, when you take a glass lid and press, it is non-blanchable because these lesions are called palpable purpuras. So please remember, students, whenever the word palpable purpura comes, what should come to your mind is small vessel vasculitis. And this condition here, which is generally IgA mediated, is called as Knox-Schonlein purpura. The new name for this condition is IgA vasculitis. Next is a case of a 30-year-old female who presents with a facial rash associated with photosensitivity and joint pain. So we can see this erythema over the malar area which spares the nasolabial fold. We're talking about acute cutaneous lupus erythematosus. This is called ACLE, acute cutaneous lupus erythematosus, which is seen in systemic lupus erythematosus, which is a photosensitive rash. A 30-year-old female presents with a facial rash and skin lesions over the knuckles with proximal muscle weakness. So if you look at the facial rash, you can see this lesion over here. You can see a violaceous macular erythema in the periorbital region. This is referred to as heliotrope rash. This is a heliotrope rash. You can see violaceous flat top papules over the MCP joint and IP joint. These lesions are referred to as Gottron's papules. So there are skin lesions. There is involvement of the proximal muscles. We are talking about dermatomyositis. Next, we have a 20-year-old female who presents with a violaceous indurated plaque. So there's a hard plaque which is violaceous in color. On skin biopsy, you see a following feature. What do you see? You see a box which is shown here. And if you see the appearance of the biopsy, it is box-like appearance. Why does it happen? Because if you see, this is the epidermis. And you can see throughout the dermis, what you see is depositing here is collagen. So there's increased deposition of collagen, due to which what happens is in the dermis, you get that box-like appearance when you take a biopsy. This condition is called as morphia. Morphia is also known as localized scleroderma. So what do you mean by localized scleroderma? The thickening is restricted to the skin. We call it as localized scleroderma, which is called as morphia. A 23-year-old female presents with history of tightness of skin over the fingers and the face. So they're talking again about a scleroderma kind of presentation and presents with these skin lesions. So if you look at the face of the patient, what you see, this is called as mask-like faces. Because you can see that wrinkles are absent here. There are absolutely no wrinkles because there's thickening of the skin over the forehead. You can see a pinched nose. You can see multiple reddish spots which are talking about the telangiectasia. So you can see telangiectasia here, dilated blood vessels, and then you can see this perioral furrows. There's a lot of fibrosis happening in the skin over the face. So that's a mask-like faces, and you get this both. You get white and brown pigmentation together. This is called as salt and pepper pigmentation. salt and pepper pigmentary abnormality. So in this context, we're talking about systemic sclerosis. Okay, here the difference between morphea and systemic sclerosis is here not only the skin is involved, it also involves fibrosis of the internal organs. Next, we move on to genodermatosis. A 15-year-old male is brought to the pediatric clinic for the evaluation of multiple dark spots on the skin. So when you look at the dark spots on the skin, what are these lesions? These lesions are called café-au-lait macules. These are called café-au-lait macules. For the diagnosis, 6 or more should be there in number. Then what else you look in these patients is you look for the presence of these cutaneous neurofibromas. So these are called as cutaneous neurofibromas. These are tumors which arise from the connective tissue of the peripheral nerve sheath. And then you examine the axilla. What do you see? You see multiple hyperpigmented small lesions over here. These are referred to as axillary freckling. So axillary freckling, café-au-lait macules, cutaneous neurofibromas. We're talking about neurofibromatosis type 1, also referred to as von Reckling-Hausen disease. Von Reckling-Hausen disease. Next, we have a 16-year-old female who is brought to the pediatric neurology clinic due to concerns about frequent seizures and skin lesions. So what do we see here, everybody? You can see here the presence of this oval on one side, pointed on the other side. These are referred to as ash leaf macules. They are hypopigmented skin lesions, ash leaf macules. Then you have these reddish brown papules which are distributed over the nose and the malar area. They are called as adenoma sebaceum. They are called as adenoma sebaceum. On the lower back, what do we examine for? We look for these leathery plaques which are referred to as shagreen patch. Examination of the nails reveals fibromas. So these are periungual fibromas. They are called as Cohen's tumors. So ash leaf macules, adenoma sebaceum, shagreen patch on the lower back, and Cohen's tumors around the nails. We're talking about tuberous sclerosis complex, which is a autosomal dominant disorder. Next, we have a 3-month-old male infant who is brought by his parents due to persistent dry scaly skin since birth. The parents report that the child was born with a tight, thick skin membrane that covered the body. So we can see the membrane which is covering the child's body. This membrane is referred to as collodion membrane. So this membrane is called as collodion membrane. And once this membrane gives way, what happens is you get the presence of these scales, which are called as the dark plate-like adherent scales. You can see these dark plate-like adherent scales, and many a time what happens when the membrane gives way, you get the outward turning of the eyelid, which is called as ectropion, the outward turning of the lip, which is called as eclabium. So this together is talking about lamellar ichthyosis. So lamellar ichthyosis is a form of congenital ichthyosis. It's a congenital autosomal recessive ichthyosis. So ichthyosis is a condition which is characterized by fish-like scales. Fish-like scales here. The next case is of a 6-month-old male infant who is brought to the pediatrician by the mother, concerned about this persistent reddish purple mark on the left side of the face. So on examination, we can see a unilateral reddish purplish skin lesion which is distributed over the face. It is persistent since birth. The correct answer for this question would be a facial port wine stain. So please remember, students, this is a facial port wine stain, which is an example for a capillary vascular malformation. This is a capillary vascular malformation, and together with this facial port wine stain, if you have epilepsy in the brain and glaucoma in the eyes, then we call it as Sturge-Weber syndrome. So Sturge-Weber syndrome will have 3 components: the skin component, the eye component, and the brain component. Next, we move on to skin and systems. A 30-year-old male is presenting with these red tender nodules on the shin. So these red tender nodules, anterior aspect of the leg, heals without scarring. This is talking about erythema nodosum, which is an example for septal paniculitis. Paniculitis is inflammation of the subcutaneous fat. A 10-year-old boy is brought in by the mother with complaints of rough, bumpy skin on the arms and the thighs. So on examination, you can see that there are multiple hyperkeratotic follicular papules distributed over the elbows. The correct answer for this question is going to be phrynoderma. What is phryno? Phryno means toad, derma means skin. What is the association of this condition? We have 2 important associations: essential fatty acid deficiency and vitamin A deficiency. A 9-month-old male is brought to the pediatrician with 2-month history of persistent diarrhea, irritability, and a rash. So there is diarrhea, which is telling there is GI involvement, and there is a rash. If you look at the rash, it is perinasal and perioral. So once you have a periorificial dermatitis associated with diarrhea, we think of acrodermatitis enteropathica, which is an autosomal recessive disorder where there is defective transport of zinc here at the intestinal level. Next, we have a 42-year-old alcoholic male who presents to the clinic with persistent diarrhea, rash, and confusion. On examination, we see that there is a rash which is predominantly distributed to the photo-exposed areas. So, all the photo-exposed areas, the dorsum of the hands and the V area of the neck is involved. So, this is a photodermatitis. So, if you have photodermatitis, then you have diarrhea, and if there's dementia in the form of loss of memory or any CNS symptoms, this 3 is going to qualify as pellagra. Pellagra is B3 deficiency, vitamin B3 deficiency. One more hint for pellagra. The question is alcoholic. So chronic alcoholism predisposes the patient to develop pellagra. A 30-year-old female who is obese is presenting with this blackish discoloration. So when you look at this blackish discoloration, there's hyperpigmented velvety plaques. The correct answer here is Acanthosis nigricans. The most common association of Acanthosis nigricans is obesity due to the association with insulin resistance. A 40-year-old female presents with diabetes and these yellowish skin lesions over the lower extremities. So if you have these waxy yellow atrophic plaques with surface telangiectasia, anterior aspect of the leg, this condition is called as necrobiosis lipoidica diabeticorum. So this lipoidica is representing the fat deposition in the skin, diabeticorum because the association is with diabetes. A 40-year-old diabetic male is presenting with these asymptomatic skin lesions on the dorsum of the hand. On examination, you have an annular plaque, central clearing, no scaling, no itching, distributed on the dorsum of the extremities. The first differential for this condition would be tinea corporis, but please remember students, tinea is itchy, tinea is scaly. So in this background, the correct answer is going to be granuloma annulare. Granuloma annulare, what is it? It belongs to a group of disorders called as necrobiotic disorders. So it's a necrobiotic disease. So what do you mean by necrobiosis? Necrobiosis means degeneration of collagen. There is degeneration of collagen fibers in these conditions. A 45-year-old female presents with asymptomatic skin lesions in the periorbital area. On examination, you have symmetrically distributed yellow color papules and plaques. So when you think of yellowish lesions in the periorbital region, think of xanthelasma palpebrarum because xanthos means yellow. So there's fat deposition in the skin. 50% of the patients generally have hyperlipidemias. Will have hyperlipidemia. A 60-year-old male presents with an asymptomatic slow-growing lesion over the medial canthus since 3 years. On examination, you can see there's an ulcer, which is a slow-growing ulcer with these beaded margins. So this is going to be a rodent ulcer, also known as basal cell carcinoma. So please remember, students, if there is an ulcer which is slow-growing with beaded rolled out edges, then think of basal cell carcinoma, which is known for its local invasion and metastasis is rare. Conclude, one important message which I want to give all of you students is the key to success in entrance exam. Now when we look at the trend is definitely going to be self-directed learning. Now when I say self-directed learning, it is the student or the learner is the one who takes up the initiative rather than looking at external sources of motivation. It is very important that we ourselves understand why are we preparing for this exam and why do we want to do well. In self-directed learning, which the NMC clearly tells us now, is where you identify your learning needs. Okay, first you understand why exactly are you studying, and then you make your goals as to what you want to achieve, and then finally you stick to the resources of learning. Don't go for shortcuts because usually shortcuts is something which lands us into deep trouble. Go for basics, go for something which is very hardcore and which you can retain for a longer duration of time, and lastly you evaluate the learning outcomes. So how do you evaluate learning outcomes is by doing grand test. So this is something which nobody should postpone till the end. Give the grand test at the earliest, get your baseline score, and that will make it more easier for all of you to upskill and learn your lacunae so that you'll be able to do better in the upcoming exams. So wishing you all the very best for the upcoming exams. Thank you.